Welcome to AETCM. Today we're going to discuss a case about a 56-year-old female who came to her ER with complaints of vomiting and generalized tiredness and decreased food intake. Shall we begin, sir?
Yes.
So, initially, she is a known case of tubercular meningitis. So, on initial assessment, she was conscious oriented. Coming to airway was patent, no secretions were noted. In breathing part, air entry was bilaterally equal, respiratory rate of 18 per minute, and saturation of 95% maintained in room air. In circulation, BP was 120 over 70 mmHg with pulse rate of 80 per minute, and in disability, GCS score was full and pupil was bilaterally equal. Exposure wise, temperature was febrile and GRBS of 120 milligram per deciliter. And adjuncts, coming to adjuncts, we took a VBG. VBG was showing calcium level of 0.61.
Okay, let's wait here. Now, we have a 56-year-old lady. You said she's a known case of tuberculous meningitis. She has come to the ED with multiple episodes of vomiting. So, at this juncture, what are the things that you will consider? What are the problems that you will consider at this point, or how will you go about to manage this patient?
As she is a known case of tubercular meningitis, the vomiting can be caused by drug-induced gastritis, which
Okay, intolerance to ATT. That is what you are telling. So my question will be, when the patient usually presents with intolerance with ATT. So usually when they tolerate it, when they start ATT in the initial days, maybe the first weeks, they will come with vomiting and all. But then you have to tell me how long since she is on anti-tubercular drug, what all drug she is on taking now.
So she has been on second line ATT drugs since the past 1 month.
Since past 1 month. So you are anticipating her to come with intoleration to ATT less likely. So it is not going to be an issue with ATT. If ATT related intoleration, usually it will happen in the first 2 weeks. Usually they will start the medication, then they will give a multiple episode of vomiting. They might have some hepatitis and they need some drug modification. So if it is probably intolerance to ATT, it will usually happen in the initial days. But here she has already completed 1 week and she is on an alternative regimen. Why she is on an alternative regimen?
So initially she was started on a normal anti-TB regimen.
Okay.
But she developed hepatitis, drug-induced hepatitis.
Okay.
And
see, another thing that can happen here is that TB meningitis, rather than ATT, one more drug we will give usually. What is the other drug? If there is a tuberculoma or anything, to decrease the edema, we will give dexamethasone also. If she is taking dexamethasone, that also can cause gastritis and vomiting. And she can come with, that can happen at any point of time. So we have to take, one thing is that clear is that when the ATT has been started and what all drug she is on right now. So it can be anything to whatever she was taking. So anti-tuberculous drug, related intolerance, but usually presents in the first initial weeks, but here it is 1 month. In between she had an alteration in the regimen also, and later on she will be on dexamethasone. She was
started on dexamethasone near this 1 week back.
Okay, so 1 week back she was started on dexamethasone. So probably it will be attributable to the dexamethasone induced gastritis. So that is a reason. What are the other possibilities that you will consider
As
here?
it is a TB meningitis, there is because of the raised ICP.
ICP, okay. So you are telling that because of the raised ICP, she can have vomiting. So what are the other signs that you need to look in for when she has a raised ICP? You said vomiting can be attributable to raised ICP. Fine, I agree to it. So what are the other things that you need to look in for the features of raised ICP? Hypertension, okay. Altered sensorium. Most importantly, they can have altered sensorium, pupillary asymmetry, they can have seizures. So anything, they can just come in with multiple episodes of vomiting. Headache, most common one, raised ICP, headache. So she don't have headache.
She had occasional
headache. Headache was on and off. Hypertension.
No
hypertension. Then what else she had? She had altered sensorium.
No
altered some pupils.
Pupils are
equally reacting. So we have to keep that as a differential diagnosis. Why she is developing and raised ICP? Why a tuberculosis patient should develop a raised ICP? TB meningitis patient should develop a raised ICP.
One, because of non-compliant to the medications or drug default itself. If all the dosages are not appropriate for the patient, then the active infection itself, if it spreads, it can cause.
Okay, you're telling that the meningitis part itself can cause. Okay, suppose what would be the other reasons for raised ICP?
Cerebral
What is the problem in tuberculosis exactly? Inflammation. So it can actually block the ventricles and the patient can go for an hydrocephalus. So that is the other thing. So they can have an hydrocephalus and features of raised ICP. So at that time they might be immediately taken for a shunt surgery and all. So these things also you need to keep in mind. So TB meningitis, with the background of whatever she has, with this background, ATT, first thing what we have to consider, but after 1 month, so we'll list it as third or fourth. Then dexamethasone, obviously, yes, last 1 week she has been started. And also back in your mind, intermittent headache, we need to say whether it is a raised ICP. And again, as you said, ATT regimen was not correctly done because of the hepatitis and all. Maybe disease reactivation or disease not controlled well. So that could be the reasons why she is developing this vomiting. Then what could be the other reasons? Other reasons for vomiting.
any
Common reasons. Next common reason.
Any
A female patient coming to you, she's a diabetic.
known case of diabetes.
Diabetes on steroids. Now coming with multiple diabetic ketoacidosis. That can be one of the other differential diagnoses. What else can be? Most common feature of this thing is vomiting. Urinary tract infection. The most common complaint that a patient might complain is for a UTI will be multiple episode of vomiting. They might come with a lower abdominal pain, they might not have, but they will be having multiple episode of vomiting, minimal headache due to secondary to dehydration, multiple episode of vomiting, and they might be having underlying fear. Since this patient is already on an ATT regimen, almost all the bacterial infections will be covered with the ITT regimen. If she's on rifampicin, it has got very good antibiotic coverage, antibacterial coverage. Then she's on levofloxacin. Again, it has got very good coverage. So we have to keep that also in our mind. So then, what will be the other possibility for vomiting?
gastroenteritis.
It can be a simple gastritis, acute gastritis. Maybe for the whatever she has taken for the last 2 days, we just need to go back and see the history. Then, diabetic lady, vomiting. Myocardial infarction, inferior myocardial infarction. That is the other differential diagnosis. So we have to list our diagnosis in a way that which will be most fitting for this patient. With this background history of tuberculosis meningitis and recently started on dexamethasone, my first differential will be, one of the differential will be drug-induced gastritis, that is secondary to dexamethasone. Second list we will have to keep raised intracranial tension, as you said, she has occasional headache, and the third will be your other common causes for vomiting. Your other common causes of vomiting will be your urinary tract infection, your diabetic ketoacidosis, your with this background history, because she is recently started on steroids, all those things. So diabetic ketoacidosis and having an myocardial infarction, atherosclerosis chances is very high. So we have to list that down. So this will be my priority. Now let's see what are the issues that we can have in airway for this patient. She is otherwise conscious oriented. So what are the anticipated problem in the airway? What are the anticipated problems?
Aspiration.
So if she is having recurrent vomiting, the most problem will be aspiration. Very common aspiration, but she is otherwise conscious oriented. She has her airway reflexes protected. So right now she is not a very high risk, but always we need to consider that aspiration is one risk factor. Then in breathing, what are the issues that you can have in breathing?
One, because of dyselectrolemia, hypokalemia loss, respiratory muscles can get weak.
Okay. So what will happen? The electrolyte imbalances in vomiting. What are the issues that you can have? Acid-base disturbances and electrolyte disturbances when a patient is having vomiting.
Vomiting mainly cause hypokalemia.
Okay. Metabolic alkalosis. So metabolic alkalosis causes hypokalemia. Hypokalemia causes metabolic alkalosis. So it's vicious cycle. So you have to understand that. So you need to control vomiting. Then you need to correct the potassium. Then only the metabolic alkalosis will subside, then only the hypokalemia will come down. So it's a rotation. So it's a vicious cycle that you need to keep in mind. So when you have diarrhea, what will have? You are more prone to develop acidosis. In this one, vomiting, it is more prone to develop metabolic alkalosis. So what was the EBG finding? pH. So again, when you are commenting about acid-base status, the first thing you have to tell is pH. Electrolytes, everything we are getting in the in the electrolyte. That is not the thing. We are looking in for pH, PO2, PCO2, bicarbonate. These are the 4 things. Rest additional things are add-on things that is you are receiving in a blood gas. So routine blood gas analysis means only for these things. Your additional co-oximetry, that your fetal hemoglobin, carboxyhemoglobin, that is an additional thing. Additional getting electrolytes, that's again another thing. Creatine, bilirubin, everything is an additional thing. When you said an acid-base status, pH, bicarbonate, PCO2 and PO2. So can you just tell me?
pH is 7.38
38, okay.
with PCO2 of 39.7
Okay.
and PO2 of VBGS.
Okay, it's a venous blood gas, okay.
And bicarb of 23.
23. So she has not gone into an extent of metabolic alkalosis. So she doesn't have much of a metabolic alkalosis. So otherwise her pH is maintained. So it is not even towards an alkalotic range. It is in the normal range only. 7.35 to 7.45, 7.398. So it's reasonable. What are the other electrolytes that you got in this?
In electrolyte, there was calcium was in the lower side.
Start with sodium. We have to calculate the anion gap, or if needed. Sodium?
130.
Sodium
130. Okay. What does the sodium says in her? 130 is the sodium. So what is your idea regarding sodium of 130? Are you happy or not happy? What does the sodium tell regarding our fluid level in the body?
Basically, if sodium levels are high, it signifies dehydration.
Okay.
But in this case, considering the background history of TB meningitis, if it is the vomiting is because of the cerebral edema, we would like to keep it at least in the...
No. My question is 130 sodium, what would be the reason? That is the first thing. Then you said is correct. 130 sodium, what should be the reason for sodium of 130?
Can be associated with vomiting.
It is a simple depletional thing. For initial, it can be depletional, or we don't know, it can be an associated SIDH also, because she has already having TB meningitis. So it can be part of your SIDH, or it can be part of your depletional hyponatremia. So if it is depletional, what else you should check in for?
Potassium.
Chloride. Sodium and chloride always goes together. So see, let me know the chloride level.
97.
97, it is normal. 97 is not very low. 97 it's normal. So 130 sodium and 97 chloride, it is almost equal, or if she has received some treatment for outside, that can alter. But otherwise it looks okay. So if sodium is low, chloride is also very low, that means there is significant depletion of fluid. So you need to replenish the fluid as well as the electrolyte. As she said, you need to target a sodium of maybe on the higher side if there is evidence of raised ICP. We need to take a 145. So that is the cutoff. So here the sodium low can be secondary to vomiting, but can be a part of SIDH also. We are not very sure. She is not consuming any food since last 2 days. So that can be attributable for her hyponatremia. Then potassium.
Potassium value was 3.5.
3.5, that's again in the low normal range. So it's not very low, it is in the low normal range. Then you said regarding calcium.
Calcium was 0.61.
So calcium 0.61, you have to be specific. This is the ionized calcium. This is the ionized form. It will reflect your normal calcium, but that will not give you sometimes a real calcium. Suppose this patient is hyperventilating and coming to you. So ionized calcium will be very low, but the real calcium may not be low. So ionized calcium, the patient is not hyperventilating. What will happen when the patient is hyperventilating? Suppose the patient has come for a panic attack. They will start hyperventilating. So there is a lot of carbon dioxide washout. Similarly, there is a shift of calcium resulting in hypocalcemia and tetany. So that is the reason why they have paresthesia, numbness, tetany sort of a thing. But once that is settled, the calcium will again shift and it will be normalized. But here the hypocalcemia is whether it is due to real deficiency, we need to see. So we need to send a serum calcium, then we can have a correlation. If it is a real deficiency of calcium, we need to correct it. You have seen a calcium of 0.61. What will be the next investigation that you will send?
Albumin can be sent. And serum calcium and albumin.
Serum calcium and albumin. What is the next, as an ED physician, what is the next thing that you need?
ECG.
ECG. You have to look for an ECG. Why you want to look for an ECG? Why you want to look for an ECG?
ECG, as calcium is of great value.
So what do you want to look in ECG? That is only my question.
QT prolongation.
QT prolongation. So what is the QTC for this patient?
500.
So in your management, what all things you will keep in mind? So this patient has come with vomiting, very important. This patient has come with vomiting and you are finding a QTC of 500.
So patient, there is high chance that the cardiac
No, this patient is having vomiting, and you have found out that QTC is 500, which is higher for this patient. You should have a 450, 470 maybe for this lady. Female maybe 470, 480 maximum, but 500. What is the most important thing as an ED physician? The patient has come with vomiting. This is my clue. What will you give for vomiting?
MSZ.
Ondansetron. Ondansetron is very notorious to increase the QTC. So you have to be very cautious when you are administering ondansetron. So QTC prolongation is known to be caused by MSZ also. That is ondansetron also. So you have to be very specific. You have to give some other agent for as an antiemetic agent. For like example, perinoma or something, you need to give as an antiemetic agent. That is the one thing that you need to keep in mind. So QTC prolongation can be attributable to hypocalcemia. Suppose you are giving again a drug that can increase the QTC, this patient can go into what? It can go into a ventricular arrhythmia. So that is very important. So when just like that, when you have simple practice, we just give pantoprazole and ondansetron as a first shot. But what can happen? The ondansetron 8 mg, it can again increase the QTC, and she can go for a ventricular arrhythmia. So we have to be very careful when you are administering these drugs that can prolong QT interval. What is the other drug that can prolong QT interval?
Digoxin.
Which is the other agent which has been banned now? They are not using any antihistamines. They can cause torsade. Torsade. Can torsade is point, and it's not been on practice. It has been banned. It has been not in use. We have got fexofenadine and all those things. It was been banned. That we can find out, right? Okay, so it's an antihistamine agent which is not being used. So you have to check the drugs that you are going to give before you administer. Quinine, very important. When you have this malaria, anti-malarial agent, quinine, that is again can increase the QTC. So you have to be very, very, very specific when you are very, very careful when you are administering these drugs. Okay, so let's come back. Airway, we have said. Breathing, we have said. Then coming to circulation. There was no evidence of hypotension, but that might not be seen because she is having mild vomiting only. So what are the evidence of dehydration? I wanted to know.
Any dehydration evidence like in tongue?
Yes.
Then how's the skin turgor?
Yes. How is the skin turgor? I want to know about it.
It was normal as.
It was normal. So she was not having any evidence of dehydration. Okay, fine. Then coming to disability, you said GCS of 15 by 15.
And
pupil was bilaterally equal. So it's very important in this patient. Now you have given her some antiemetic. You have settled her. Now how will you proceed now? So the patient is in front of you. She has come with multiple episodes of vomiting. So you have stabilized her. You have given an antiemetic. You are started her on an IV fluids, and you have sent your lab investigations. How will you rule out each one of this? Whatever we have discussed.
So we can roll out mainly is it drug induced or not?
We can't stop dexamethasone also in her. So one thing, we can convert to a parenteral route. Instead of an oral route, we can convert to a parenteral route. Then what else we can do? We need to rule what was the second in line. Raised ICP. Raised ICP was the second in our differential list. So what do you have to do?
You can go for a
imaging. You can go for a repeat imaging if there is any complications related to TBM has developed. Whatever I have discussed before, whether the disease is under control or she has gone for an obstructive hydrocephalus. A plain CT should do, or before that you can just do a papilledema. Look for a bedside retinal examination that can give. If there is a papilledema, definitely it is due to raised ICP. And that is the one easy thing that you can do if you don't have any imaging facilities. So a plain CT can look for hydrocephalus, but ideal will be an MRI with contrast, which can see whether there is any tuberculous enhancement and all those things, whether there is any tuberculoma, all those things. You will get a better idea when you go about with an MRI. Okay. Then what you have to do? You have to look for the other causes. You have to take an ECG. You have taken an ECG. You didn't have any other STT changes except for this QTC. Then you have to look in for infection, urinary tract infection. What was her blood sugars?
Blood sugars was just normal within 190 GRBS.
190 GRBS.
Then so DK was CRP.
Which one was elevated?
CRP.
CRP was elevated. So elevated CRP, how will you justify in this patient?
So it can be attributed to patient was having vomiting and any abdominal, any infection can cause elevated CRP.
Okay.
Which which in turn can cause
See, the TB meningitis, if it is partially treated, that itself can cause an increased CRP.
CRP.
Second one, it can be a superadded another infection as a urinary tract infection. That can cause increase the CRP. So these are the all reasons, whatever we have listed can increase the CRP also. So then, what are the other things? GRBS is under control. LFT you want to check?
LFT want to check because of as he is ongoing with the ATT and she had a history of ATT induced hepatitis.
So I'm asking you, you can test one investigation in LFT. You can't send SGOT, SGPT, you can't send bilirubin. I am telling you, you can send one investigation. Which one will you select?
Albumin.
SGOT or SGPT? One drug induced we wanted to know. That's only one investigation. Enzyme should be more than enough. Among that, SGPT will be more than enough for a drug induced one. So you need to check it for that. That is a one investigation, or else you can ask for a PTNR. PTNR will give you how the liver is functioning right now. Whether due to this factor deficiency and liver failure, the patient has gone into any liver failure, you will come to know. So this investigation you ask in for, you do an imaging and looking for the reasons why she is having headache, because a urinary tract infection also can cause this headache. That is also a possibility because of dehydration. Then what were the other lab investigation
Lab
results?
investigation, INR came out to 1.26 and in OTPT was 33 and 15 and ALP was 114.
Okay.
CRP elevated to 130.
130. What was the serum calcium?
Serum calcium 4.6.
What is the reason behind? Is corrected calcium?
Corrected calcium 5.6.
What is corrected calcium? You have to correct for the albumin. Suppose the albumin you take as 4 as normal. For every 1 decrease, you have to increase 0.8 to the serum calcium level. So she's having 4.6 and her albumin level is
Albumin is
2.8 or something. What was 2.8?
2.8.
So we have to add 1 to the serum calcium. So around 5.6. So 5.6, why she vomiting? Can it cause hypocalcemia?
Vomiting this much, very minimal can be caused, but this much of reduction is
Should not be there. So hypocalcemia, what is the most common reason for hypocalcemia?
infection.
Hypocalcemia, most modern cause. What this patient is having?
TB.
Vitamin D level. What is the vitamin D level?
Vitamin D level was very low this patient.
So vitamin D deficiency, that is the most important reason for hypocalcemia. So the dietary supplementation is not adequate. She will be around 54 menopause age. So requirement is high. She need to have at least 1500 to 2000 milligram of calcium a day, which she is not receiving. Also vitamin D deficiency. That's the most common reason why we have all those osteoporosis and bone fractures and all. So you have to treat vitamin D level. How will you treat vitamin D?
Vitamin D can be given
How? Orally.
orally.
You can have tablets or you can have powders. You can have 60,000 sachet, 2,000 sachet, everything is available. But initially, you need to have a higher dose of vitamin D. Maybe 60,000 international units you can give for the first 2 to 3 days. Then you can make it weekly and monthly to be continued. So that is the vitamin D deficiency that you need to do. And similarly, you have to treat the calcium also. So calcium, again, the QTC is getting prolonged here. So you need to give an IV, but potassium is on the borderline. We have to see that also. If it is further decreasing, you have to be very careful. I am giving another scenario. A patient is there in the ICU. Okay. So you have a patient who has been NPO for last 4 days. And today you have started feeding for her. Okay. And the next day when you are looking into her electrolytes, she has hypokalemia, hypomagnesemia, then hyperglycemia and hypernatremia. So what will your differential diagnosis at this point?
Because as the patient was in NBO for the
For last 3-4 days.
Last 3-4 days, we are suddenly giving a large amount of feed, which in turn can cause increased insulin secretion, which in turn cause electrolyte shift.
So what is that called as?
Refeeding syndrome.
Refeeding syndrome. So refeeding syndrome is the one thing that you need to keep in mind when you have a patient in ICU or prolongedly they are not taking feed. Suddenly you have started feeding and patient has gone into hypokalemia and all those things you need to check in for. So they will have hypokalemia, hypophosphatemia, hypomagnesemia, hyperglycemia and hypernatremia. So that is a classical presentation what you will have in refeeding syndrome. But here the calcium deficiency we can attribute to vitamin D deficiency. So start replacing the vitamin D and you start giving her high doses of calcium for time being till the calcium level improves. Okay.
Calcium and magnesium are interrelated. So hypomagnesemia again can
Cause,
hypocalcemia.
so you have to again correct that also. Okay, fine. So what was her urine routine finding?
Urine routine showed 10 to 15 pustules with numerous RBC and bacteria was also present.
Okay. So, what is the next investigation that you would like to have?
Serum electrolytes should be checked.
Serum electrolytes should be checked. We have checked already.
Yeah.
What urine? Urine?
Urine culture.
Urine culture we need to send. Then
Sodium,
urine sodium,
magnesium.
urine magnesium, all the electrolytes, because in urinary tract infection there is no point in sending all this tests because it will be high, because urine is not able to, the kidneys might be affected. If the kidneys are affected, they might not be able to filter off these electrolytes. So if the patient is having hypokalemia, you have to send a urinary potassium you to see, but here the cause is very known because the patient is having multiple episode of vomiting. So urine culture, then you have to go for a basic ultrasound abdomen. Any other reason? Maybe amylase lipase, depending upon the patient has abdominal pain, you have to keep pancreatitis as the least differential diagnosis. So that will be our initial this thing. So what you did for this UTI?
For UTA patient, we had hydrated hair and also again an antibiotic.
She's already on levofloxacin, no?
Antibiotic.
She's already on levofloxacin, rifampicin. So what could be the reason for an UTI? What could be the reason for this UTI here?
Maybe it is one resistant bacteria.
Okay, she was in the hospital for few days in between. So it's a multi-drug resistant, or it can be part of the TB itself. We don't know whether it's a TB itself is causing the UTI. It is the tuberculosis genitourinary TB. She can have a CNS TB and a genitourinary TB. So we are not very sure, and we need to continue evaluating for that. Why she's having this urinary tract infection. So you have to await the culture. Maybe urine AFB we need to see, whether the gene expert we need to send for urine, and you have to see whether evidence of any TB is also there. Okay, so basically a patient coming to you with vomiting, it can be due to, you have to see the background history. That is the most important thing. The patient is having an underlying problem, you have to treat that underlying problem. What is the underlying problem here is TB meningitis, ATT, dexamethasone, and she's also diabetic. So that is how we came down on the differential. This could be the differential number 1, whether it is a dexamethasone induced gastritis. Differential 2 was the raised ICP. We ruled out by taking an MRI. MRI was normal. Was normal for her. Then we came down for a urinary tract infection, and urinary tract infection, it was positive. So we have to treat that also. So time being, we have to look in for why she is developing a UTI, whether it's a multi-drug resistant UTI, or else it can be a tuberculosis UTI also. So these are the things that we need to do. How is she now?
She is getting better. Started on fluid correction and electrolyte correction.
She's okay now. Okay. Fine. Thank you.